Hi everyone. Thank you so much for joining this important conversation today, and thank you to the World Health Organization and FHI 360, firstly for this important and excellent contribution to the global ECD knowledge base, crucial as the sector continues to support, advocate for and fund ECD programs for young children and their caregivers during the pandemic and beyond, and secondly for inviting us to speak today. It's been a pleasure working with you both in such a challenging time for the initiatives, services and programs that promote and protect nurturing care. And I'm so looking forward to hearing from the researchers and the programs and the countries that have participated in this work and who've shown such adaptation and innovation in order to reach families during this time. The LEGO Foundation aims to build a future in which learning through play empowers all children to become creative, engaged, lifelong learners. And as we all know, parents are fundamental to that aim as the first and most important carers and teachers in that child's life. COVID-19 has meant families have been isolated under financial pressure, and caregivers are at much greater risk of increased stress, depression, anxiety, and violence in the home. And at the very same time, the services designed to support them can't reach them in the usual ways. We've been amazed at the dedication, ingenuity, and determination of our partners to continue to deliver for and improve the lives of children during this crisis. The LEGO Foundation has been proud to increase our investments and support of partners at this time by being flexible and responsive, enabling our partners to pivot their focus to address the needs of the moment. We hope that we've also supported the ECD sector knowledge base and advocacy tools with important research such as this. Our Playful Parenting initiative has 4 main aims. Firstly, to accelerate the scale-up of quality parenting interventions that support the use of play to promote children's holistic development and to strengthen primary caregivers' demand for playful parenting. Secondly, to invest in implementation science to better understand the impacts of messages, modalities, dosages, technology, and other aspects of implementation so that funders, policymakers, and practitioners can make more informed decisions. Third, to support greater uptake and monitoring of best practice in large-scale parenting interventions. And fourth, to equip key sector leaders with the knowledge and skills that they need to integrate play-based parenting approaches across health, education, and social protection systems. We want to see a seismic mindset and behaviour shift from parents and caregivers, from understanding to enacting and ultimately advocating for investments in and support for parenting interventions. Developing the workforce to better understand the importance of playful parenting and learning through play is critical to this. And ultimately, we want to aim systems to influence systems to better invest in and support playful parenting interactions to systemically reach children with learning through play. The 2 pieces of work that we're learning more about today are encouraging, but also present gaps that need filling. In the first, in the rapid review, we learned of the sheer dearth of research on play during the period of the COVID-19 lockdowns. Knowing how crucial play is and how the broader evidence base shows the impact on early child development, parent-child relationships, caregiver mental health and well-being, we believe it's important to explore and learn how play has been impacted, as this has implications for children and families' development, health and well-being. The second piece of work, the case study brief, underlines how various programs around the world have adapted quickly to the crisis by adjusting priorities and applying innovative ways to reach children and caregivers, giving us an insight to the barriers and facilitators of remote program delivery. The case studies have given us learnings about the different ways in which play and playful parenting messages have been incorporated into these innovations, which we can further learn about and explore in our programming and use in our advocacy as we all continue to face the challenges of reaching caregivers in this global pandemic. We hope we can balance innovation with maintaining quality. Young children have been largely absent from the public debate and public policy about the pandemic's impact on children and caregivers. We hope that this contribution will inform the ECD sector as we all work to support families and children in this challenging time and beyond. But I'd now like to hand over to Dr. Christy Hackett, Global Health Researcher and Consultant of the University of Toronto, who will go over the findings in more detail. Thank you.
Thank you very much, Gemma. I'm actually going to pass it along to Sheila just before we jump into the research results.
Thanks, Gemma. Thanks, Christy. Hi, everyone. I'm Sheila Manji. I'm with the World Health Organization. And indeed, we're going to jump in and spend the majority of our time today on the results and learn more about what different organizations have done around the world. You're going to hear a lot about the impact of COVID-19 on nurturing care, in particular, three components of nurturing care: safety and security, opportunities for early learning, and responsive caregiving. Now, before we go into all of that, I wanted to share with you a new video that is coming out today. It's a short animated film on the topic of responsive caregiving during COVID. It is 1 minute and 10 seconds, so very short, very easy to fit into your day, and very easy to share with friends, family, colleagues, wherever you are. I'll show you the video in just a second. I just want to give you some background before we do that. This video is the third video in a series of videos that's being produced by the Partnership for Maternal Newborn Child Health alongside the World Health Organization and UNICEF, and it's being developed with Studio Ixaris and with support from Medical Aid Films. These videos began very much in response to the pandemic, recognizing that women, children, and adolescents, issues that pertain to this population, could come under certain constraints, and wanting to make sure that we didn't lose sight of things that would be important for women, children, and adolescents around the world. So there are already 2 videos available, one on the topic of breastfeeding and a second video on the topic of adolescent mental health. And the one that we'll show you today is the one on responsive caregiving. There is another video that will be coming out soon on the prevention of violence against women. These videos are all available in multiple languages, and they also have a social media toolkit, which you're welcome to use to help you spread the word on your various channels. So I'm just going to stop my video and share the screen so I can show you. Here we go. This is the page. We'll put the link to this website in the chat for you shortly, and you'll be able to see all of the videos here, as well as the social media toolkits. And we'll just take a minute here to watch this video together.
The COVID-19 pandemic is a challenging time for children, parents, and other caregivers. Working from home, school closures, not seeing friends and family as often, and financial insecurity has made it harder to provide the love and care that children need. Doing a few simple activities with your child can provide them with comfort and love during these uncertain times. With your baby or toddler, cuddle them. With your young child, read a book. With your household members, dance or sing together. With your older child, show interest in their hobbies and allow them to have positive interactions with people. With children of all ages, setting healthy routines for eating and sleeping are all important contributions that you can make. If you feel overwhelmed, take a break. Try a few minutes of deep breathing and time for yourself. You will be better able to take care of yourself and your child.
So just to let you know that the breastfeeding video that came out in May last year, it had over 80 million views in the first 6 months. And because of partners and interest from partners, the video was translated into additional languages. So the videos are always translated into the 6 UN languages of English, French, Spanish, Mandarin, Arabic, and Russian. But the breastfeeding video actually is available in up to 15 languages. So there's if there are ideas, if there's interest in using the video in different ways or in having it translated, do not hesitate to contact us. The videos are all available on YouTube, but we will send you now shortly in the link and then in the chat. And then again, when you get the recording for the webinar, you'll also get the link for the video and all the materials that go with it. We're hoping that this video gives a little bit of insight into what can be done in these times to support caregiver mental health, and also provide a few very simple suggestions on what caregivers can do in their everyday routines, everyday activities at home to continue to provide responsive care for their children. So thank you. With that, I'll turn it over to Christy.
Wonderful. Thank you, Sheila. I've got my camera on. There we are. Great. So welcome, everyone. Good morning, good afternoon, and good evening to all. It's so exciting to have such a diverse set of participants today, and I'm really looking forward to the discussion. So as was already mentioned, I'm going to spend about 10 minutes just giving an overview of the research project and summarizing some high-level findings. And then we're very fortunate to have colleagues from all 7 case study programs on the call today, and each will have about 5 minutes to share some of their experiences with you. And following that, we'll move on to the interactive Q&A session. So we do hope that everyone can stick around for that part. So for a bit of background, FHI 360 is a global human development and research organization based in Durham, North Carolina, and Washington, DC. And I am currently working as a research consultant on this project with FHI 360. So in the summer of 2020, FHI 360 was asked to carry out a broad, rapid review of how nurturing care has been affected by the COVID-19 crisis, and to explore program examples of what innovations have emerged so far from the adaptations during this difficult time. So this work was completed with the guidance and collaboration of our colleagues at the World Health Organization and with the support from the LEGO Foundation. This 2-part review was completed over a period of 4 months. So both the rapid review and the case study component focused on 3 elements of the nurturing care framework: responsive caregiving, opportunities for early learning, and safety and security. So the rapid review, which was led by my colleague, Dr. Carrie Poole, who's on the call today, identified a few key findings, which are summarized here. So we found consistent evidence across country contexts that the pandemic has contributed to increased parent and caregiver stress, burnout, depression, and anxiety, which was linked to less responsive parenting. In addition to this, referrals for child maltreatment drastically dropped during, along with school closures and other transmission reduction measures that were put into place, which raised concerns that child abuse and neglect may be undetected or underreported during the pandemic. And lastly, we found very little evidence regarding early learning and children's play. So this highlights a key gap in the current evidence that we have related to nurturing care during the pandemic. Now, today's focus is really on the qualitative case studies, which you've heard a lot about. And these are really looking at nurturing care related programs from 7 different countries, which we've mapped here. Findings from this research are drawn from a desk review, as well as in-depth qualitative interviews with about 40 stakeholders across the 7 programs. And you received a link with the webinar invitation, but it's here again and will be shared through the chat box as well. If you'd like to access both the research briefs and full reports, they can all be found there. So there were a number of priorities that emerged across programs that we documented through the interviews. First of all, many of the programs sort of shifted their priorities really quickly at the beginning of the pandemic to respond to social protection for immediate health and nutrition needs. And this was done directly in some cases, or in some cases through referral to other organizations. Secondly, a number of programs focused on this emergent need to support caregiver mental health through social support and or stress reducing activities. And thirdly, a number of programs also shifted their focus to develop strategies to promote positive caregiver-child interactions, and in some cases encourage playful parenting. And our research team found it quite interesting that these shifting program priorities actually address a number of the key gaps that we identified in the rapid review in phase 1 of the project. So we also documented a number of key strategies that were common across programs. The first one being this focus early on in conducting community-based rapid needs assessments. So really understanding with new data what the current needs were, emerging needs were, and how to adapt quickly as those lessons emerged. Secondly, a key strategy was to be comfortable taking risks and being able to pilot new ideas. Third, the use of instant messaging and social media platforms to share parenting and early child development content was a common strategy. And lastly, we saw a few examples of programs attempting to embed their responses within existing delivery systems. So really collaborating or leveraging connections across the education, health, and social welfare sectors. Of course, there were a number of common barriers that also came up. Things like technological challenges, which I know everyone on this call surely can relate to. Things like, program participants having competing childcare and household demands, not being able to have that physical contact with children. And I learned, of course, that, particularly in clinical settings where programs are dealing with children with developmental delays or disabilities, that lack of physical contact was difficult to adjust to. And then, of course, we also documented initial difficulties with the remote or online delivery models, such as being able to assess people's body language on Zoom or Skype, engaging participants, and being able to integrate play remotely. There were also a number of common facilitators. So things like having flexible donors willing to shift funds to try out new activities, having an innovative mindset, having staff with effective and motivated leadership in place, also having staff with strong advocacy skills. So folks who are really able to identify resources, identify new resources, or generate new existing resources to really meet communities' immediate social protection needs. And lastly, having strong community partnerships to begin with and being able to leverage local contextual knowledge during this time proved to be a common facilitator across contexts. So this will be my last slide before I hand it over, but one of the really interesting parts of this research for our team was to see some of these unexpected positive outcomes emerge despite all the challenges that these programs encountered. So the first one, and this was the most common, that the pandemic really created this catalyst for quick creative thinking. And that was true across many contexts and may not have happened in the absence of the pandemic. There were also stories about opportunities to engage male caregivers. So during a lockdown period when in communities where men are often working outside the home, they're now stuck at home, with their families, but are now really actually quite excited and willing and available to engage with ECD activities offered by the programs. Many interviewees also shared that they were surprised by how they were able to establish meaningful connections with caregivers, despite not being able to connect in person. So that was a positive. In some cases, we saw improved social cohesion and community trust. And I think this reflects, many of the program's ability to address those immediate needs. A positive to come of that is that, those connections with communities and the trust is actually improved because of this experience, this shared experience. As I mentioned, using social media and digital platforms to reach families increased the reach of many programs, and it also increased participant diversity. So that was a positive that, some families who couldn't participate in programs in person are now able to connect remotely. Again, as I mentioned, this increased intersectoral collaboration created new opportunities to integrate ECD. So whereas it may have been perceived as a lower priority across different sectors prior to the pandemic actually sort of raised that ECD on the priority list. And it was sort of an opportunity to integrate content into existing systems. And lastly, we also heard that online engagement was in some cases a better option for children. And I think this was particularly true for children who have particular special needs. So children with social anxiety, for example, actually really enjoyed connecting with other families online. So with that, I'm actually going to hand it off to our first program representative, Gwendolina Curry from 21 Luglio in Italy. So I will pass it over to you, Gwenda. Thanks, everyone.
Okay, hello, everybody. So I will try to be quick. So Associazione 21 Luglio is committed to support families living in condition of extreme poverty or cultural deprivation, discrimination, and social exclusion. Our effort to support children and family follows a systemic approach of concentric circle from the individual child to the family, to the community, and upstream institutional factors such as education system and government agencies. A majority of our program take place at the Polo Ex Fienile, which is a large cultural and education center located in Torbella Monaca, which is a peripheral suburb of Rome. Our neighborhood is characterized by high crime and dropouts rates and is home to a quite large drug market. So as a result, distrust and suspicion are deeply ingrained, and residents are generally reluctant to trust people outside their immediate families. There are several activities that our organization carries out, but having little time available, I'll tell you about one, the Baby Play Space. It's a space where children from 0 to 4 years old can come and play with their caregivers together with the ACD professional 3 times per week, now actually 4 times per week. Although school service for early childhood in Torbella Monaca in the neighborhood are very few, before the pandemic there were few children who attended our spaces. During the first week of the lockdown, which began in Italy on March 9, 2020, we did a quick search to identify the needs most present in fragile families with small children, and we realized that they were often linked to basic needs: diapers, wipes, baby food, milk powder formula. So we decided to transform ourselves to raise funds and start distributing baby packs. We worked with a pediatrician and a midwife to define what to include in each of the 5 types of package divided by age from 0 to 3 years old. With the possibility of reopening after a few months, we reopened our center respecting, of course, the anti-COVID-19 measures, so mask and gel and distancing. And we began to take advantage of the large garden of the center and reopened the activities with the baby space and in conjunction with the distribution of the packages. So we decided to do both activities together at the same time. This has led to a tripling or even more of the number of the children attending the activity. Furthermore, each delivery of the package became a moment of conversation with the mother. I, as a social worker, started to have a one-by-one interaction and conversation. And this allowed us to get to know and support the families in a more in-deep way. From these interviews, for example, we see that some special needs emerged for foreign mothers to learn, for example, Italian language. So we decided to start an outdoor Italian language course for mothers while their children are cared for by ACD professionals. So mothers came, and they still come, and to attend our Italian language course when their baby are quite close in the big garden, playing with our ACD professional. Or again, during these interviews, the difficulty of some mothers to manage breastfeeding or other aspect of infant care emerged. And we therefore organized meeting with a midwife once or 2 or 3 times at least. So in this way, we could support the mothers, especially in this moment of great isolation and loneliness. We found this working very, very, very good. And we didn't expect such a growth of our community. As I told before, there were not so many children attending our activities before pandemic. And now everything has changed. Currently we have 85 moms with their children coming to our center. playing with our ACT professionals and knowing each other and exchanging their experience and facing their problem, also exchanging their experience. And we are going on. And right now we are starting other 2 courses about feeding and how to improve and how to shift from breastfeeding to start to baby food. And also we are going to create and to start other courses for our mothers. So we hope they will help them to find a job, because of course one of the greatest problem is the lack of work and the loss of their job. So this is one aspect of how we get surprised, also in a positive way, from the pandemic and what we had to do to face it. Now,
Thank you.
Okay, I think I will turn it over to my colleague, Dr. I don't know if I pronounce it well, Rupa Srinivasan from Umid Child Development Center, to speak about their experience in India.
Thank you so much. That was perfect. You pronounced my name perfectly well. Hello from India, and thank you for the introduction. And I'm going to dive right in. And I'm going to begin by sharing a story with you about little Avni, who you'll see in the picture. There you go. There she is. She's flanked by her parents in this picture. And as you can probably see, she has Down syndrome. And Avni's family was coming to our center for early intervention services prior to the pandemic. And with the imposition of a nationwide lockdown at the start of the pandemic, this family was thrown into a crisis mode. Her mother, who was a domestic helper, lost her job. Her father, who was working in the unorganized health sector, had to face huge pay cuts. And overnight, they had to face shortages in food supply, and they did not have access to basic needs in their house. So we started off on a note like this, and wherever we looked around, we were hearing similar stories of spiraling domestic violence, of abuse. And as you heard earlier in the presentation, that families were often conflicted by the different demands that were posed on them on this time. And for families such as Avni's, the early intervention services did not seem like a priority at that time. And it was also not surprising, given all the stories that we were hearing around us, that both caregivers and providers at this time were feeling extremely overwhelmed and burnt out at this stage. So we are a not-for-profit organization in Mumbai who work with children with disabilities directly and who offer capacity building for those who work with children with disabilities or are at risk for it, such as parents, community health workers, and professionals. Many of the challenges that the pandemic was posing to us was not our core area of expertise. So next slide, please. So when families were struggling to meet their basic needs, there were food insecurity issues. We obviously, that seemed like an area of huge priority. And we then partnered with community-based organizations and other not-for-profits to try and meet these needs immediately. In addition to this, supporting the mental health of not just the caregivers, but also the providers seemed to be of utmost importance. We have a strong mental health component, and the pandemic actually spurred us on to think of creative ways of providing mental health support to families as well as the providers themselves. We co-created resources such as videos and booklets along with caregivers, and I'm going to share some of the links to these resource materials in the chat box in a little while. And the caregivers actually named them as our life hacks. This was called Mere Hamare Jugaad in Hindi, which literally means our life hacks, where they talked about the little big things that they could do for themselves exactly the way as it was shown in the video that could preserve their mental health. We continued to provide intervention services to children with disabilities, and we used telehealth just like the rest of the world. But when we started, there was no blueprint to do this. And we had to figure out our way within a population where many did not have consistent access to internet. So we used the hierarchy of connectivity. We started our way with video calls and synchronous telehealth delivery, and worked our way down to audio calls and asynchronous telehealth delivery, depending on what worked for each family. We created best practice documents based on our experiences, some of which have been used as resources by other not-for-profits and have also been used by state units of UNICEF in the country. As we look ahead, we are in the middle of the second surge of the COVID-19 pandemic in India as we speak right now. But as we look ahead, we are hopeful to carry some of these learnings even when all this is past us. And on that optimistic note, I would now like to hand over to the next speaker, Carmen Patterson-Payne from the Nobody's Perfect Parenting Program in Canada. Over to you, Carmen.
Thank you, Rupa. I'm just going to pull up my notes here. Sorry about that. So hello, everybody. I'm honored to be talking to you from Winnipeg, Manitoba, Canada. Winnipeg sort of sits in the geographical center of Canada on the traditional territory of the Anishinaabe, Cree, Oji Cree, Dakota, and Dene people, and the homeland of the Métis Nation. I'm a provincial coordinator for a great parenting program called Nobody's Perfect. I'm also a master trainer for the program. Just to give you a little bit of background, Nobody's Perfect is a support and education program for parents of children under 6, and it was developed in the 1980s by Health Canada and is now the intellectual property of the Public Health Agency of Canada. The program is about helping parents and making connections and building communities of support, sharing experiences and gaining confidence, coping skills, and understanding of themselves and their children's development. So it's delivered in a variety of early childhood settings and family resource centers and other nonprofit or non-government organizations all across Canada. It is free for parents and is voluntary. So each province and territory has a coordinator such as myself to support facilitators who run the program with parents and trainers who train facilitators. And we collect data and sort of monitor group parent outcomes and such as that. Nobody's Perfect has been successful because of its strengths-based and participant-centered approach. And the program meets parents where they're at, and we guide them to where they want to go. And we know that when parents build their own capacities, that this has a direct impact on the healthy development of children. So when COVID-19 hit and we were all under stay-at-home orders, program facilitators reached out to how best support families at this time of need while being apart. And so some asked if we could do the program virtually, and which had never been done before. And at the same time, agencies were reaching out and inquiring about virtual facilitator training. And so that was our challenge. So in Manitoba, I responded quickly by setting up Zoom calls with my facilitators just to connect with them and share ideas on how best to adapt the program to virtual format. And at that time, at the same time, all of us provincial coordinators started to meet regularly. And we basically became each other's cheerleaders, and we gave each other encouragement to do what we thought was possible in our area of the country. And we created strong collaborative partnerships, most notably myself in Manitoba and my partner in crime, Connie Herman from Saskatchewan. Some coordinators do Nobody's Perfect sort of off the sides of their desks, and we have dedicated time in our work. So we sort of took this project on. The program objectives are to connect parents, to find other resources. So the flexibility and adaptability has always been a strength. So we were confident that we could move this virtually, but we just didn't know how because we didn't have guidelines or best practices to rely on. But we knew that we needed facilitators to focus on connectedness with parents. Facilitators found ways through a variety of platforms such as Zoom, but also WhatsApp, closed Facebook groups, Messenger. They posted information on social media platforms. And so they started to just meet with parents, and they learned very quickly that parents just needed to talk with each other to normalize stress and struggles that they were having. We learned in our weekly check-ins how facilitators adapted the program, and some shortened the length of the groups because children were present. Some facilitators included children in their parent groups, which hadn't been done before. They read stories together, they did rhyme time, songs, they taught each other rhymes from their different home languages. Facilitators even dropped off art supplies and snacks for the children on doorsteps for their weekly sessions, and encouraged community walks to find teddy bears in windows. Facilitators reported that those connections were being made for sure. And I see that I'm almost done. Regarding the virtual facilitator training, initially we had said no, and we decided 3 months into the pandemic that because the parent group outcomes were happening, we needed to make this happen. And so we have now done 12 pilot trainings online. Our very experiential training does transfer to Zoom, and thinking outside the box and having a collaborative approach has made this successful. There's no turning back now. We will run Nobody's Perfect groups virtually and training virtually, because we have been able to connect people from all across Canada that we would never have had been able to do before. So we're very proud of that work. And thank you. And I am very pleased now to introduce Dr. Natalie Tarpak from Colombia.
Thank you very much. It's a pleasure to be here with you. Next photo. Next slide, sorry. So I'm going to try to present to you the 3 key problems we did have, the main key problems, and the proposed solution, to protect kangaroo mother care in Colombia during the COVID-19 pandemic. When I'm speaking about kangaroo mother care, I'm speaking about skin-to-skin contact, breastfeeding, early discharge at home with a strict follow-up up to 1 year. So you can imagine that it is not compatible with social distancing. So we didn't want to step back to malpractice and separation of the mother and baby. So it was not easy. Next one. Next slide. Okay, so the first key problem was the fear of all the parents and health professionals that more than anything, health professional, that parents and baby could be contaminant. So the challenge was to have reliable data to convince our colleague that it was possible to continue with kangaroo mother care with biosecurity measure. So in Colombia, we did have each month a report of the cases of COVID, and very quickly it was possible to show that newborn was only 0.1% of all the cases. So it was a solution, trying to react not emotion-based, but data-based, and health ministry since March, with the Kangaroo Foundation and the Neonatal Society, we were able to publish recommendations for the kangaroo mother care program in the hospital, in ambulatory, and to update them using the evidence that was good evidence, scientific evidence available. Next one. The second problem, a key problem, next slide, was how to adapt. If you do another time, the next slide, we will have the next photo, please. So, okay, so the second key problem was how to adapt the NICU for kangaroo mother care. So the solution was to separate COVID zone of non-COVID zone. And in the non-COVID zone, to work with kangaroo and breastfeeding, and only one, the mother was with her baby. I just want to remind you that parents are not a visit for their infants. parents are parents. They must be able to come and to stay all the time with their infant. For this reason, I'm not speaking about parents' visit. Okay, so the mother was coming alone, and when it was not the mother, it was the father. And in the how you say that, in the COVID zone, while the parents were testing to be negative, one member of the family could come, carry the baby in skin-to-skin contact, and sending videos. So we were really trying not to separate the baby from his mother. Next one. The third, we cannot loot that. I mean, it's not possible. You cannot put 2 meters. Let's be reasonable. The next one. So the third key problem, how to adapt the ambulatory follow-up program, the KMC program for the premature and low birth weight infants. I just forget to say that it's only for infants, no? For premature and low birth weight infants. Look, mothers are creative. The next one, they are able to find solution. Next one, it was before and after. Next one. The solution, cleaning protocols, biosecurity measure. If you protect yourself, you will protect the other. So it was our goal, our challenge, and we were able to do it. Next one. The 53 kangaroo mother care program in Colombia are working well, actually, according to the recommendation of the Health Ministry of Colombia. I will let my colleague from Jordan to present her experience. Thank you very much.
Thank you, dear. Hi, this is Ghada, the Early Childhood Coordinator for IRC Jordan program. So I would like to talk first about the parenting program as education, a main education intervention for early childhood in Jordan. The parenting program that is being implemented in IRC or through IRC teams, it has 2 different modalities. The first one, which we call it the low contact. We conduct regular sessions and workshops for families, for caregivers, 7 workshops or 7 sessions. And there is a different toolkit that we usually use with the children who are within the age group 3 up to 8 years old. And during the pandemic, which is in March, has started in Jordan in March 17th, and where was a huge lockdown announced and happened all over Jordan, and the governorates were completely separated from each other. The staff of the INGOs and national NGOs could not move, including the IRC staff for sure. So we couldn't, in a way or another, move or reach to families. So we had to adapt the modality and make it remote or virtual. And the only means for gadgets that are available with families was at that time the smartphones, and sometimes the phones were not smart. So in a way or another, we had to convert the content into phone calls in a way or another and make the sessions through phone calls. And since we were successful in reaching the families and chat with them, give them some time to release the pressure through the phone call, and sometimes we used to connect the families together when they give us the consent. So connecting them through the conference call, it was so successful. We thought that Reach Up and Learn, which actually a parenting program that has been delivered through home visits, can be also remote. And now I'm going to talk about this program specifically, which is actually a very important modality that started in Jamaica during the 70s, and it has been expanded globally. This program, we usually deliver health messages and early childhood development messages for the caregivers of children aged 0 up to 3 years. And at certain point, we have to assess the impact of this program. And since we were passing through the pandemic, we converted the program again. We adapted the program to remote through phone calls. So the community health volunteers in a way or another deliver the messages through phone calls. The first 5 minutes, usually it is chat, and then 15 minutes are given to the health messages, awareing the parents about the chronic diseases and so on, and 15 minutes delivering the early childhood education or development messages to the parents, giving them some tips and activities, learn to play activities specifically in order to engage them more in the parenting. The nice thing, can you go back to the first slide, please? So one of the lessons learned during our intervention was that the facilitators or the community health workers preferred the in-person training because the Zoom or the Skype was not enough for them. So we at certain point we had to see them in person and deliver the training for them. And the facilitators usually they are the volunteers who usually conduct the phone calls, 30 up to 40 families, the caseload for each CHB. The caregivers at the same time required more tips about the protection and more tips about the cognitive skills and how learn to play activities, sharing with them more cognitive skills and social emotional learning. Next slide, please. In a way or another, COVID had one of the things that we have learned through COVID. We have to, as I said before, we have to create a different modality, which is remote, and to compare between the in-person and the remote. And also, in a way or another, to modify the design of the research in order to cope with the pandemic situation in Jordan. Now we have passed through the second surge, and hopefully we will not go through a third one. So till now we are conducting remote services, including this program, which is Reach Up and Learn. We have finished the baseline, and now we are conducting the community health messages through the phone calls. Passing to my colleague from Philippines, from MAPA program. Please start.
Thank you, Gada. Magandang gabi. So our parent support intervention is called Masayang Pamilya para sa Batang Pilipino, or MAPA for short, which means Happy Family for the Filipino Child. Next slide, please. So this program is our local culturally adapted version of the Parenting for Lifelong Health programs, first developed and tested in South Africa, and now being implemented in several parts of the world. The program aims to prevent child maltreatment, primarily by strengthening the parent-child relationship. Caregivers learn to apply such practices as one-on-one time and praise, which form the foundational walls of the house you see here. They also learn effective behavior management strategies such as redirect and using consequences, which forms the roof of this happy home. Caregivers also apply mindfulness exercises to manage stress. Now, MAPA is originally conceived as a group-based program. Trained community facilitators work with caregivers via collaborative discussions, a lot of practice and role plays, and coaching and role modeling. So you could see from the photos in this slide that so much of the intervention itself is in that interaction between the facilitators and the caregivers. Facilitators undergo a 5-day training program and receive high levels of supervision. So we've found in our small-scale trials that the MAPA program delivered in this way was effective in reducing violence against children, generally sustained even a year after the program. Prior to the pandemic, we were preparing to engage in larger trials in different regions of the country, integrating MAPA in the Philippines conditional cash transfer system. However, the pandemic happened, and this sort of intensive in-person parent group intervention was not possible. But more than ever, we had to continue to engage with families in some way. So with our global PLH partners, we had to reimagine our models, and the pandemic pushed us to innovate in various ways. Next slide, please. So for example, we pared down the PLH parenting messages into core essentials and converted them into tip sheets translated to several international languages and all the major Philippine languages. These resources are freely available to service providers and families everywhere. We've emphasized new content around the benefits of play in the home, benefits for learning, relationship building, and stress relief. These tip sheets have been disseminated across our engagements with our partners and stakeholders. For example, they are used as guides in clinical consultations in child protection units in hospitals all over the country. Via webinars and radio programs, our facilitators have trained service providers on these MAPA core skills using the tip sheets. We've transported the MAPA collaborative facilitation style as best as we could in the online platform, engaging in live demonstrations and role plays, using videos, eliciting participation using the chat feature of Zoom, and leading mindfulness exercises with hundreds in the Zoom space. This month, we are launching the feasibility pilot study of the chat version of the MAPA program, which is a parent group support intervention delivered over the Viber application. And last but not the least, we are now working to integrate and scale these digital MAPA resources into the family development services of our government's conditional cash transfer program. So delivering parent interventions at scale is always a challenge, but we are realizing that these models of delivery, whether fully digital or combined with in-person, may afford us a wider reach than the face-to-face program, at least for families who may not require intensive support. Needless to say, these new modes of delivery have also required innovative research and evaluation strategies to determine their feasibility and effectiveness. So now I turn it over to my colleague, Lana Karuskina Drivdale from PATH, to speak about their experiences in Mozambique.
Thank you very much, Leanne. So we can move to the next slide. So PATH is a technical assistance provider working primarily on supporting nurturing care for ECD through the Ministry of Health platforms, focusing on 0 to 3s. So I'm going to just talk about a couple of resources we have developed during COVID pandemic. We did not have a lockdown in Mozambique, but we had reduction in different activities. Schools were closed for a while. Many consultations kind of decreased their volume, but then went back to, to normal. So we had to adapt ourselves as well. So somebody asked in the chat whether it's possible to support families if you don't have access to internet or phones. So the interventions I'm going to talk about are not requiring neither internet nor the phones. Before COVID started, we used to support Ministry of Health to promote playbook sessions in the waiting rooms, because we found that families spend long hours waiting for consultations in the waiting rooms of the health facilities. And it was a great way to really use that time to teach caregivers, particularly mothers, how to play with their babies. But with COVID, our district services recommended not to continue this activity. So we were thinking what we could do, because caregivers are still there, are still coming, but they cannot engage in play activities anymore. So we had some materials already developed for radios. And what we did, we basically placed mobile radios into the waiting rooms with pre-recorded sessions geared both to children and to caregivers. So we had songs, very kind of dynamic songs in local languages, and then had a few interactive skits, almost like role plays, pre-recorded role plays for caregivers, talking about child development, male participation, etc. And I think what really worked for us is that before, when this content was passed on local radios, we really were not able to reach mothers. It was primarily fathers who are usually kind of in control of the radios, right, in the families. So by placing radios in the health facility waiting rooms, we really were able to reach mothers. And when we interviewed them, we were able to see that they really were capturing messages. They were able to give examples of specific practices they adopted, such as making toys from recycled materials, or talking more to the child, talking to the baby during pregnancy even, and also even sing back some of the songs that they heard on the radios. Of course, there were some challenges as well. Radios also required batteries, so we had to afterwards move to solar radios, which was great, and it works very well. We've noticed that it's not enough to just put radio to play. It's good to accompany with a little bit of an introduction facilitation. So that's it's still being a bit of a challenge, and we're still trying to see who in the health facility can support. But overall, we feel like the results are outweighing the challenges. And let's move to the next one. So the second interesting innovation we developed was a story. You know, we talk a lot about play being therapeutic. I would say that storytelling is also very therapeutic. And so when we started supporting our Ministry of Health to develop some of the COVID materials, we've noticed that there is really nothing geared at children. At the same time, we were receiving, PDF files of books from Brazil, from other countries, which were not really adapted to our context, right? It was more like urban environment, kind of well-to-do families, white families. So we thought, okay, let's see what we could do. Could we develop a local story based on a typical family and a typical, context that the family would find themselves during COVID? And so this is how a story of 6-year-old Vanya emerged, where she's learning what COVID is and what she can do and how she can still play and learn and stay healthy during COVID. It was a long process to get it out. We worked with 3 ministries, which is quite difficult, but managed to get approval from 3 ministries. And the story is now being disseminated. It's already been published, also disseminated in online format. And one dissemination channels that I would like to share with you is dissemination through community radios. We are partners with a local organization called H2N, a communication organization that works with community radios. So we have shared the story with them, and for a while they didn't really know what to do with it. But then one radio kind of went ahead and dramatized the story, and that really kind of lit the light bulb and was really helpful experience for other radios to see what you can do with a story. And so afterwards, over 80 radios went ahead and actually dramatized the story as well and put it online for the listeners, and encouraged parents and children to call with their questions, and even encouraged children to draw drawings based on the story. So it was really kind of pretty rapid dissemination through the community radios. And the feedback we received is that children and parents really like the simplicity of the story, the local context, and would actually like to see more stories like that. So we're now thinking, should we have a sequel to Vanya? Maybe not on Corona necessarily, but on other health-related or nutrition-related issues. Thanks very much.
Great. Thank you so much, Shalana. I just want to jump in here to express my heartfelt thanks to all of our program representatives today and their teams, not only for contributing to our webinar today and the discussions to follow, but also for somehow finding the time to participate in our research study, despite the many competing demands of their own during this difficult time. So on behalf of the entire research team, thank you all. We're so grateful for you taking the time to share your experiences. And at this point, I am delighted to hand things off to my colleague from World Health Organization, Vanessa Cavallera, who will moderate our interactive Q&A session. Over to you, Vanessa.
Sorry, I was muted. All right. I want to echo your thank yous to everybody who's contributed to this research, but also to our FHI colleagues. They've been a great partner to work with. And from the WHO perspective, this has been an incredibly valuable effort to look at the aspects of nurturing care beyond health and nutrition, where a lot of literature and investment can be found in response to the pandemic. It's true that the COVID-19 is a health emergency, but what these pieces of work have highlighted is that the implications of the pandemic have affected the lives of children and their families much more broadly, and with what we can only expect to have long-term impacts. So as all emergencies, this has been a learning opportunity for us, but we've been into the pandemic for over a year now. And so this piece of work was also aiming to look at identifying what our priorities should be moving forward. And what the case studies and the literature have found, they have shown us that the resilience and the ability to respond that different players can have to adapt to such challenging and changing environments to continue supporting children has been amazing. It's been truly inspiring, and I hope you share this feeling after the presentations that you've heard today. It's time to start thinking about the next steps and fill in the gaps that we've identified with this work. And to ensure, for example, that a lot of these innovations have been revolving around digital support, right? Digital ways to reach the beneficiaries. And so we need to ensure that equitable access to technologies becomes a priority, to identify ways to include how to identify and refer suspected cases of child neglect and maltreatment in a digital area where programs are being delivered that way, and also how to continue promoting and supporting and providing early learning and opportunities for play during times of confinement where schools are closed and caregivers have conflicting duties in the home. So lastly, some of the findings pointed to the importance of addressing caregiver burden and their stress, and how that impacts the care that they're able to provide to their children. So how supporting caregivers, which we know should be a priority in normal circumstances, but becomes even more essential in such extreme situations. So we see implementation research as a key way forward. And, in addition to that, a lot of questions have been raised in the chat, and we will get to that, about provision of care to more vulnerable groups, for example, children with disabilities. And there are other groups that may benefit from hybrid approaches to care. So how can those be implemented and designed in circumstances like a pandemic or any other emergency? So there are a lot of open questions. So we have more, I think we have opened more questions than provided answers in a way. But at the same time, it was great to see also what the response has been, the spontaneous response has been from different programs and different players. So this is kind of just an overview from us, and to thank all the participants, and really to have this group think about next steps and way forward, and also to open up the floor for discussion if there are any questions or any inputs. I think some of the questions that have come up in the chat are really key and are really focusing around how can play be supported throughout a pandemic and all the related restrictions. So how can we make sure that play remains a priority and it's something that children are able to do and caregivers are supported to teach them how to do it? And also, how do we overcome the physical limitations that the pandemic imposes and make sure that children feel that support with limited, embraces and touches from, a broader, beyond the family. And then the issue of childhood disabilities and children with special needs. How are they taken into account with these innovations? So these are some of the questions, and I'm sure we have in the audience a lot of people who have dealt with this in their programs and in their day-to-day practice. So let's see if we have anyone who wants to contribute from the participants.
May I perhaps take the one about including children with disabilities?
Of course.
Okay, so I think thank you for the question. So our early childhood development program has two components at Umeed in Mumbai. We have a center-based component and a community component. The center-based component, of course, continued to offer both assessment and intervention services to children like Avni, who I spoke about earlier in my presentation. And we used a staggered approach depending on what worked for families. Some of the support was offered on an individualized basis, but we also had group support programs for families. So we had families support groups that were run on video calls. And we also had fun clubs for children where they could come with their family members and the family members could be supported in playing with the children. Because we could see the children and the family in the video, it gave us access to what was available in the home, and we encouraged families to use what was available to continue to play and work with their children at home. And in the community setting, once again, we already had a pre-existing early childhood development model. We had to convert it to a model that could be delivered online. So one of the first things that we had to address was familiarity, digital literacy or internet literacy, before we could convert many of the components to an online mode. And like I mentioned earlier in my presentation, even before we went into early identification and intervention during the time of the pandemic, our main focus was also to look at the mental well-being of both the community health workers as well as the families in the community. And we focused a lot on that in the initial stages and then went on to the intervention phase.
Thank you, Rupa. I think this is a great example. I heard someone was trying to take the floor. And please either raise your hand so we can give you the floor or unmute yourself. So maybe if we don't have any comments from the floor, I would ask my panelists for one round of, if they had to provide one lesson learned, the most important one, what would that be?
Well, I would like to add here, one of the things that we used to apply through Reach Up and Learn and Low Contact, when we do the remote intervention, which is a phone call, for example, we divide the time and we focus on delivering a very basic activity and to the parents, so they can, and very practical, so they can immediately implement it with their children. Recycling some items from the house, like plastic cups, for example, or a bottle. Creating toys from those very basic items in the house, in the kitchen, for example, and making them toys, how to take care of those toys and make them so clean. And usually we explain to them the learning outcome that the children usually gain or reach from this specific toy, and how to use it as well and apply it. So it should be a very short message. If we are doing virtual service, it should be short message to the point, and it is basically activity where the parents can recycle some of the things inside the house.
Thank you. Yes, no, I think this is a key aspect. Also, the transition, both for, I would say, from the training perspective and as well as service delivery. When we transition from face-to-face to online, the communication should be much more practical and much more concrete, and in a way shorter and more to the point, like you just mentioned, to make sure that the key informations are passed on and are very concrete in terms of true activities that whoever is on the receiving end can practice immediately.
May I say something?
Yes, please.
So I just want to say that what was key, kangaroo mother care follow-up, we are doing a follow-up with psychomotor development, evaluation, neuromotor development. We are looking at the eyes because they are premature low birth weight infant in follow-up during the first year. I believe that we must think that teaching parents, and you will have, we are not alone. We are not alone in front of parents and their baby. When you explain them the problem, they are able to understand. So we are together how to do the thing better. And it's another way to see the thing. It's not us in front of them. So if you put, I am saying that because for example, in one of the excellence center where I am, we are looking at 60 infants per day during the pandemic. And we didn't have any diffusion. Why? Because first, you don't have, infants clearly are not contaminant as it was, we thought at the beginning. Second, you have a rule. The rule, if you protect yourself well, you will protect the others. So parents are understanding that, and we are working with them, and I'm agreed that we don't look beautiful with all these things. We look like extraterrestrials, but it doesn't mind, yeah? We were able to continue, and what surprised me is that parents want to come. They want to be, it's presential. Majority of the work is presential because parents are not agree to do virtual. It's not easy. Even not all of them can do it, of course, but it's not the same. And you cannot vaccine a baby virtually. And you cannot do a neuromotor examination. You cannot do a psychomotor. So you cannot, there is a lot of things that you have to do with the parents coming. So doing this, I think we were able to, we didn't have any epidemic in the kangaroo program, okay? And we did a survey and everybody is in the same situation than this center in Colombia. So I just wanted to say that the important thing is parents are collaborators because they want the best for their infant in this case. And second, if you protect yourself, you protect the others. It's just a way to say that it's possible to continue the work. And it's very important.
Thank you. And that speaks also to the point that I was making before. It's true for health examinations and developmental examinations, as well as for service delivery on certain aspects. So vaccinations, but also beyond, again, beyond health and nutrition, there are still some interventions that may benefit quite a lot from face-to-face interaction. And we need to think about and learn from the experience that, we didn't have any transmissions, for example, in such settings where we're able to protect ourselves and we're able to protect the participants. So there are ways when it's necessary to do that are those hybrid approach we were talking about. So
Vanessa, can I just jump in?
Yeah, please.
Sorry, I just wanted to make a note of a few questions that I think just got jumbled into a busy chat section here, but maybe interesting for participants. The first one was there's interest in how the case study programs involved fathers specifically, or male caregivers. And I wondered if any of the panelists had some insights to share about strategies that worked well to engage male caregivers. And the second one, there's a great question about, we're hearing a lot about what worked really well, but are there examples of things that we tried and maybe didn't work so well? So maybe those two questions we can think about.
I could maybe talk to some father involvement. That was one of the things that we found, that with the stay-at-home order, dads were being taking on a more active role and feeling the same stress and mental health. and they were reaching out. So we had male facilitators. We had previously on a project trained male facilitators as peer program facilitators, that nobody's perfect. So they started dads groups. And so dads groups became the virtual connectedness for dads. And that seems to really work well for them. So dads working with dads. And I just wanted to mention that one of our lessons learned was the access to devices and internet, of course, only enlarged that barrier for our vulnerable families. And so one of the things we wanted to address in our training, on virtual training, is that we made sure that our facilitators had skills to not only run the program virtually, but to run it face-to-face. And so our training takes much longer and much more effort. And we had to actually mail things ahead of time for people so that they had those experiences so that they could transfer it face-to-face when it was safe to work with parents. So.
A great example, thank you. Any other experiences of engagement of fathers? What we've seen in the literature review is really a shift in terms of, obviously mothers were still the main provider of care for children, but we saw a true shift in how much responsibilities fathers were taking on in the home, and not only caring for the children, but in general household support. And so this is definitely, it's something that I think with the nurturing care framework, it's something that we've been putting it on the radar for quite some time now, but then translating that into programs and into practice, there's always a lag time. So maybe this pandemic sped the process up a little bit. So I see Andrew with a hand up. I would like also to encourage participants. I do think that what hasn't worked well is always a difficult topic in any type of research and lessons learned. But it's true that it's the essential one. So these are things that are not often publicized and we don't find in findings of research, but are actually key things, so that people, when they're trying to innovate or find new strategies, they don't replicate strategies that we know have not worked in other settings. So please do share with us. There's no judgment at all. Liang?
Yes, if I could speak about that a bit. It's not so much that it didn't work, but we don't know whether it's working or not. And I'm talking about the webinars that we've conducted, where we've exposed thousands of service providers to our parenting messages and parenting skills. But if you have that wide reach and not everyone answers the post-webinar survey, then you actually don't really know how much, to what extent they're using these tip sheets in their work. To what extent they've disseminated these materials to families under their care, because that's what we hope, but we don't know. So I think that's something I think we need to do a better job of monitoring and evaluating. And I think that's related to a question I wanted to answer in the chat. It's a question from Anina, who's from Nicaragua. And she was commenting on, there are so many materials about parenting and child development online. We're inundated with these materials, and I agree. And so our tip sheets are just one in the sea of materials. And her question is, how do you effectively promote meaningful use of these free resources? So in our case, it was very important for us to really pair the tip sheets with guidance for the service providers, hence the webinars. We felt that we had to provide some guidance to service providers on how they they could use these tip sheets to discuss with families, whether remotely or in small groups, depending in their community. So that, I think that was one way of ensuring that they're not just disseminating these things like flyers, but that they would really engage these topics with the families under their care. And then another question she had was, how do you monitor the reach? So as I said, one quick way we tried to do that was just a post-webinar survey. But then another thing we did for the child protection units in our context was, after 3 months, we got in touch with the service providers again. And by that time, we hoped that they had some period of time to try and use the tip sheets. And so we gathered data 3 months after the webinar to ask them again how they were using it, how many families they had reached, and so on and so forth. Thank you.
Thank you, Leanne. And I think this is another very key aspect, which is always challenging the monitoring. How do we measure impact? And with these digital interventions, it's easier in a way. Yes, there are surveys, there are questionnaires that you can easily give people access to, but you have no control on whether they will actually fill them out, and the timings and how much information you will get. So it's true that the innovation needs to come at all the different levels of the implementation. So it's the service delivery, it's the conceptual thinking, but also how do we monitor impact to make sure that what we're doing is actually working. Yes, of course.
May I just say 2 things I think are funny. We are monitoring the babies. So we looked at the impact of COVID on the follow-up, and it was 8,000 babies between 2019 and 2020. And what is very interesting, and I hope we will keep it after the pandemic, is that the readmission of this fragile infant between the discharge and 1 year just decreased like this, but 20 times. From 20%, it go to 2%. Why? Because these infants were not in contact with respiratory contact in the family. Because everybody is very respectful and will put a mask. If they begin to feel that perhaps they have something, you will limit the visit of somebody ill. And so the result, incredible. The result was really that readmission for respiratory disease just go down like this in this fragile infant. So I was very surprised. And the second thing, more exclusive breastfeeding, because the mother were at home. That's interesting for the country who don't have maternity leave or not. I mean that it's very interesting. The exclusive breastfeeding were higher up to after 6 months of corrected age. So that means 7 or 8 months. So these 2 aspects of the pandemic, let's put a positive aspect. This positive aspect is real. So I just wanted to say that.
No, this is wonderful. And I think it's important to see, as always, what are the opportunities that are emerging and what are the positive, unexpected outcomes that we're seeing out of the pandemic. And not only the response, but the pandemic, the dynamics that the pandemic itself has imposed. So, and you know, that's part of also the more balanced care in the home, you know, the more active role that fathers have been having, and all of these aspects, which is something that you know, people have been talking about, but seeing it in practice because they were forced, it's actually the new normal, maybe in a positive way. All right, so I think the time for the discussion is up, unfortunately. So I will give the floor to Elizabeth for closing remarks.
Thank you. What a wonderful and inspiring webinar. And Thank you so much to the partners, to FHI, to WHO, and to LEGO for supporting this amazing work. Sharing this, and also I would like to thank the panelists for their excellent presentations and really giving us the opportunity to share and learn from so many different countries. I just wanted also to say that those who don't know ECDAN, we are a global network that catalyzes collective action. We advocate for young children. We also share knowledge and learning between countries and between partners. And we also connect and align, which will be very important as we get out of the COVID-19 pandemic. Sharing this research is so important and so valuable in helping us understand how different countries, how different partners, how different communities have really adapted, innovated, used whatever resources they had in place. I think we've also learned about the huge growing inequalities, whether it's technology, but also children in emergency, disabled children, and those in poor settings. I think we have to do much better to reduce these inequalities as we go forward. And I think we are learning from these case studies on how that can be done. It's also very valuable, what we've shared today is also very valuable in helping us prepare for the next pandemic. This is not the last one. We also have climate change emerging. And I think what this research shows is how important household preparedness should be and be part of how we prepare for future emergencies. For ECDAN, we will build on and our partners, including the regional networks that we work with very closely. We will be building on this work. We will look at other research that is emerging so that we can continually learn what worked, what did not work, and how much more we need to continue to innovate as we go forward. I think our work is cut out for us to take to address all the huge impacts for parents and young children and their caregivers. And I am so inspired that together we can actually build back stronger, better, differently for this generation and for future generations as well. Thank you so much to everybody who put this excellent webinar together, and wishing you a good week. Thank you.